Okay, everybody, we're going to get going. Appreciate everyone jumping on with us today. Should be a good 45 minutes to an hour. Again, thank you for joining us. We are Accurate Accreditation. We are a company new to the market. About a year ago, we worked with a couple of surgery center administrators and developed a software tool that automates and digitizes the accreditation process and the compliance management process. It's an online cloud-based tool that digitizes and automates all of the manual logbooks and the paper trails and the burden of managing accreditation. And part of our system is we update it regularly because rules and regulations change regularly, as you know. And so we get the pleasure of working with folks like Alicia Johnson, who's with us today, who's a surveyor, and she helps us really maintain our knowledge base and make sure that our software stays on the front end of all those rules and regulation changes so that we can help our customers navigate the process easier. But part of what that is, we want to be able to leverage her and her knowledge and her best practices to share what she sees out in the market relative to accreditation management and compliance management. So we do regular webinars like this, and it's a chance for her to share those best practices and that knowledge base, like I said. And a quick introduction for Alicia. So for the last 29 years, she has served as a national surveyor for AAA HC. About 8 years ago, she started her own accreditation consulting company to help surgery centers around the country navigate the process. Alicia has her master's degree in public health from the University of Tennessee. She holds a board certification from the American College of Healthcare Executives, and she has experience in leadership positions, including operations, compliance, marketing, and business functions for independent as well as hospital-owned surgery centers. Her career experience encompasses dental practices, endoscopy centers, imaging centers, hospitals, and Indian healthcare centers as well. As you can see, a lot of experience, and certainly a pleasure of ours to have the opportunity to partner with her and work with her in this space. So without further ado, Alicia, I'm going to kick it over to you to walk us through your presentation. So with that, I will hand it to you and let you go. One last housekeeping note. So at the end, we'll hold some time for question and answer. At the bottom of the screen, at the bottom of your screen, if you scroll your mouse down, you'll see a menu bar pop up, and you'll see a chat function as well as a Q&A box. If you enter questions into either chat or Q&A, our team will answer those, and we will facilitate those through Alicia at the end. So with that, Alicia, I will hand it to you. Thank you for joining us today.
Thank you. Well, thank you. Can you hear me okay now?
I can hear you great.
Great, great. Okay, so we're going to talk about how to prepare for your accreditation survey and the top deficiencies of last year, how you can avoid these deficiencies, and how you can self-test, and a little bit about decreasing the stress of the upcoming survey, because I think all of us, even those that are surveyors and have done it for years and years, it's still a little stressful when your center's being surveyed. So we want to talk about which policies are required to be in writing. And as you know, in the HHHC handbook, there is a list of required policies. However, even if it doesn't say it's a policy that's required to be in writing, some of the standards say you will have a process. Well, if you can't document that process, then you could get dinged on that. So it's better to have the written policy anytime there is a process. So we're going to talk about first impressions that the surveyors get, and how to self-test, and about a mock survey. So some of the written policies that we see that most centers lack is, one, you're required to have a written policy for the isolation and transfer of patients with communicable diseases. And when we ask that, a lot of times the centers will say, oh, well, we would never admit a contagious patient. Well, we understand that. However, what if you unknowingly admitted what you believe to be a healthy patient and you had them in pre-op and you notice, hey, there's this rash on your torso. What happens then? So you have to have the written policy, but then your staff have to know too. If you have a patient in pre-op and you discover this patient was exposed to measles 2 weeks ago and now she has this rash, what are you going to do with her? So the staff needs to know where she's going to be isolated or contained and how you're going to get her out of there. Secondly, care of pediatric patients. I know all of you don't see peds, but if you do, you have to have policies for that. Policies for students. This doesn't mean if you have an occasional med school student or college student come in and just shadow for the day. This is if you have a process where you get student nurses or student CRNAs or residents. Maybe you have a program for fellows. If you have any type of program like that, you have to have those policies for students, and the chapter on education would apply to you. Next, your medical director has to have a job description, and probably more than half of the centers that I go to, there is no job description for the medical director. So the medical director, the administrator, the director of nursing, these people have to have a job description and they have to be appointed by the board. Therefore, it should be in the board minutes somewhere. Two policies that people, almost everyone has, but they don't have a clear and distinct policy. Impaired and incapacitated should be two separate policies. These are two separate things. Recall log. You have to, it's not just enough to say, well, if anything was recalled, we would pull it. We would follow the manufacturer's directions. We want to see a binder or a log where you have the evidence, and AAHC is going more and more to evidence-based. So we want to see where you keep that and how you get that information and what you do with it. Next, most everyone knows what to do when your instruments come out of the autoclave and the tests failed, the strip didn't turn. We always go in and look at your sterilization equipment and the logs and talk to the tech, and they can always tell us what they do when it fails, but you also have to have that in writing, and that's where some people get sideways. Next, armed intruder. We used to, or AAA used to call this violence in the workplace, but you know, in the last 8 to 10 years, we've seen so much more violence rather than two employees getting into an argument or a fist fight. And now we're looking at armed intruder, and that's something you need to address. Do you have a policy? Have you done any training? Have you done a drill? Do you have panic alarms? You know, what would you do in the event of an armed intruder? Next, definition of adverse events. And of course, you have some type of definition for adverse events, but what we see is that oftentimes these are incomplete. And what I tell people, the best thing to do is just take the definition verbatim from the handbook, because adverse events doesn't just pertain to the patients, it also pertains visitors, staff, employees, and not just an actual adverse event, but near miss. And you'll see near miss throughout Chapter 5. And oftentimes when we're at a center and the surveyor says, how do you manage near miss? Do you document that, or is it a teaching moment? What do you do? And you'll get the deer in the headlights look, like, near miss, what do you mean? Now, you may call it different things. A lot of people call it good catch, but you have to know what the surveyor means when they ask you about near miss. And part of orientation for new employees is going over that definition of adverse event and near misses, and the new employee knowing what your process is. So a lot of people, or I should say the majority of people, leave that off their orientation checklist. So be sure and add that if you don't have it. Medication reconciliation. And it used to be that 90% of centers did not have one in the patient chart, but people are doing much, much better with that. Also, if some of these are forms or policies that you don't have, if you want to let Susan know which one specifically, we will try to get it to you. Next, querying post-op infections and complications. And so often the staff or management will say, well, the surgeon or my doctor comes back and tells me if there was an infection. And that's not enough. You have to have a system where you're querying all the surgeons that were there last month. Here's the list of your patients that we saw, and a column where that doctor can check if there were any post-op infections, complications, ER visits, hospital admits. So you've got to have some type of formal query there. Monitoring of CO2 for deep sedation. It would seem like this would go, we wouldn't need to say that. It would go without saying, but we do go in centers that do not have the CO2 monitoring. Okay, how are you going to avoid these most common deficiencies? First of all, always review your previous deficiencies. Whether you are new to the center or you've been there for the last 3 surveys, get your report back out from last time and review those deficiencies. Make sure they are addressed, and look at the suggestions and consultative comments. Did you consider those? Maybe they wouldn't work for you. But you need to be very much aware of this, because your surveyor who's coming this next time does have a copy of your previous report, and they do have a list of those deficiencies, and it's their job to confirm that you did correct the deficiencies. Okay, look at your credentialing and privileging for all your new providers and make sure the I's dotted and the T's crossed for all of those, but also your providers that were re-credentialed. And a lot of times we see more issues with the re-credentialing than the new providers. Next, your orientation, and I think I already addressed this, but has to include adverse events and near misses. So your survey's coming up in a couple of months. Review and update your governing board minutes, and we'll talk more in a minute about what is required there. Look at your QI committee minutes. Can't tell you how many times we're looking at good, would seem very thorough QI committee minutes. Here's the agenda, here's the minutes, but nowhere in that quarterly meeting does it ever say anything about the QI studies or benchmarking. So that's part of it. It needs to be documented. You can't just assume because you have the studies and they're over here in this binder that that's enough. Your committee met, and that is a working committee, and they should be discussing the studies that are ongoing or about to start or that they've just finished, and it should be in the minutes. Your adverse incident reports, many times, and we're happy to look at your forms and give you feedback, but you have to have the follow-up on there. A patient left your center in an ambulance. What happened to that patient? Maybe you investigated why they had to go to the ambulance, by ambulance. Maybe you have, of course you have their surgical and post-op records, and you probably, a lot of times we'll see a transfer form that's complete. So many people on their actual adverse incident report do not have a section for follow-up. So what was the follow-up? Did you get the discharge summary from the hospital? Did you call and talk to the patient? And now the patient's home. They were, maybe they were seen in the ER or kept for observation. Maybe they were admitted. Whatever happened, we need the follow-up. QI studies, and as you know, AAA doesn't say how many studies you have to do or how often. What it does say that the number is based on the size and scope of the organization. So if you only have one OR and you're doing cases 3 days a week and you do 1 study a year, hey, that's great. If you have 5 ORs and you're doing 5,000 to 7,000 cases a year, you could probably easily do more than 1 study a year. Every time AAA comes, they are going to review 2 of your studies. They can be the same 2 that you sent in with the application, but they're going to review those and send those back to HHC. They are evaluated at that time. Okay. Some of the other things you need to be reviewing, your patient satisfaction surveys. The surveyor will want to see some of the return surveys. They will want to know, what do you do when you have a negative or a complaint? And you need to be able to give examples of that. Also, they're going to look in the QI minutes and the governing board minutes to see if patient satisfaction was reported and how is it reported. Next, a formal infection control, I left out the word risk, a formal infection control risk assessment. And people are getting better about this, I think, because it's been a deficiency for so many people that at their next survey, they have it. It is a tool. You can create your own. There are many out there. One of the best ones that I have seen, if you just Google CDC infection control risk assessment outpatient. I think that's a very good one. It's very long. It's about 22 pages, but it's you can complete it in an hour or less. But you do have to have that, and you should be doing one every year. And you can change them up so you're not always doing the same one. Chart audits. Are you conducting periodic chart audits? We're not talking peer review, that's something different, but are you doing nursing chart audits? Your specimen logs. The surveyor will always want to see your specimen log. We want to see how you log the specimen out, what data are you getting at that time, where's it going to, and then we want to see how did you confirm that a report was returned. And you can't say the report goes to the surgeon's office. Maybe it does, that's fine. But you, the surgery center, have to confirm that a report came to your center. Then you have to confirm that the surgeon saw the report. He should initial the report, and it should be in the patient's chart. Now, if you have EMR, that may come in as a task that's assigned to him, but you can, there again, you can look and see that he has acknowledged he saw the report. Monthly safety checklist. Someone needs to be your safety officer, and that person should have a monthly list of things they go through the center checking. And it's not enough just to say, oh yeah, Mary checks the exit lights, and Susan checks emergency lighting, and you need to have it in writing. So we want this list, this check sheet, this log that they use to show us that it was done, and specifically what they are looking at. You should have an annual hazard assessment. Some people do their hazard assessment quarterly or monthly and combine it with the safety, and that's fine also. Okay. Another thing that we see a lot that's missing, you have to have your annual education and training, not just for your staff, but for your providers. So we want to see who's doing the training, and what tools are you using for the training? Are you using videos? Are you using a professional company? Do you have a binder you've put together? But who's doing it, and where's the documentation that shows all 8 nurses and 3 scrub techs received their annual training on such and such date? So we want to see evidence of that. Next, surveillance of hand hygiene and safe sharps. And we see a lot of people that have done a QI study on hand hygiene, which is great, and they've improved the participation and correct method of hand hygiene. But even though you did that study, you have to have ongoing surveillance. So at least once a quarter, and this doesn't have to be the infection control coordinator, that she or he can assign that to other people, so that once a quarter, someone is responsible for today. They're watching hand hygiene to see if people are using it at the correct opportunities. And again, that's something that should be documented. Inappropriate use of single-use and multi-dose vials. if a multi-dose vial goes into a patient treatment area, it now becomes single dose. You cannot use it on multiple patients. You can have it in a non-patient care area, which could be a nurse's station or a med room, a pharmacy room, and draw up for more than one patient, or draw up what you need for this patient and then maintain the vial if you date the vial, because once you reach that, it's only good for 28 days, regardless of what the expiration is. Next, your look-alike and sound-alike medications. You're required to have a list. And what I see often is people have printed out this, 12-page list, and they have it in a drawer somewhere. We want to see the list of the look-alike, sound-alike medications that you have on hand, your look-alike, sound-alike medications, and that should be posted as a reminder to staff. So it could be on the inside of the med cabinet door, that would be fine. And then how do you alert? They make special stickers that you can buy that say look alike, sound alike, or you could just use, red pill and stick dots. Whatever your method, but you have to have some way to provide the alert there. Next, anesthesia consent. And you're not required to have a separate anesthesia consent. It can be on the same consent form as the procedure, but we have to know what anesthesia is planned. We realize anesthesia is a continuum. You may plan one type, but then it becomes another type. But the patient needs to know that. So you can't just have a blanket anesthesia consent. You need to have which anesthesia is planned for this particular patient for this procedure. Next, radiation signage. And a lot of you do pretty well about having a sign going into the OR doors. So you have a C-arm in there and you have a sign, caution, radiation in use. That sign is really for staff to alert a pregnant staff member. For patient safety, you should have a sign either at the front desk, it could be if all patients change, it could be in the changing room, but a sign for patients saying, if you are pregnant or think you may be, please let us know. And that relates to both the radiation and the anesthesia, so we do want to see that sign. H&Ps must be completed within 30 days. We understand patient schedule and they get sick or they get busy and they have to reschedule their surgery, and it ends up, maybe it's now 40 days since the H&P. So the doctor can update the H&P in pre-op, but it does have to be documented. Okay, annually, and I would say that this is probably right now the thing that most people miss. The board annually has to review and reapprove patient rights and responsibilities, the policies and procedure manual, the scope of care, the QI program, risk management program, the infection control program, and the safety program. And we understand the board's not going to sit there together and review a 300-page policy and procedure manual. The director of nursing and the medical director can review it and make a recommendation to the governing board that we accept the policies and procedures. These 5 policies have been added. These 3 policies have been edited. So you can do it like that. The QI program is the only program that the standards say must be evaluated. And as we all learned in school, if it's not in writing, it didn't happen. So it's not enough when you say, oh yes, at the annual board meeting where they reapprove everything, they do the QI program as well. They approve it, reapprove it, they review it. But the word in the standard says evaluate the program. So your QI program has to be evaluated every year. So all of your providers for credentialing and privileging, peer review, all of them have to have that list of privileges, and you have to have an approved time frame. The easiest way to do this is to have a letter in the chart which says, you know, something to the effect, congratulations, Dr. Smith, your privileges have been approved or reapproved effective such and such date until such and such date. Providers cannot approve their own privileges. And for all of you that have more than one provider, that works great. If you only have one surgeon, you have to get his, not just his privileges, but his entire chart reviewed by an outside physician, preferably same specialty. Okay, peer review. So the standard says peer review should be performed by a similarly licensed peer. Sometimes that's not possible, and we realize that because you may be in a small town and the only same specialty, it would be a conflict of interest or a trade issue. So sometimes you have to get a different licensed peer, and we understand that. For peer review, and as you know, for initial credentialing, you have a new physician, you're going to get letters of reference for peer review. After that first time, you don't ever have to do that again. Your peer review is going to be internal. Now, everyone has their peer review. They can pull out and show us the paperwork. That's good. But you have to have evidence that peer review is part of your process for re-credentialing. And that is what is lacking almost always. So just better documentation there in the board minutes can accomplish that. As far as privileges, what we see a lot of times, you know, the surgeons have privileges for all the procedures they do, but they don't have privileges for local anesthetic, and they're injecting local in the OR, or maybe they're giving their eye surgeons who are giving their own blocks. So whatever the case, the surgeons have to have privileges for any anesthesia. Okay. QI program, we talked about the written program has to have annual goals and a formal evaluation of the program. QI studies have to use the HHC 10 steps. And if you don't have a reevaluation, it is not a study. The evaluation of the QI program has to be reported to the board, and now also throughout the organization. External benchmarking you are required to do, and it has to be documented. So many times when we ask about external benchmarking, we hear, oh, we benchmark with ASCA. Okay, show me the data. And if you hem-haw around, if you totally ignore the question, which people do, I don't suggest you do that, you're benchmarking, even though you may not have been able to improve anything as a result of the external benchmarking, you still have to be able to show the documentation. A physician must be on the QI committee. He doesn't have to come to every meeting, but he does have to be on the committee. It doesn't have to be the medical director. You can appoint someone else. And of course, you have to have your internal benchmarking of important aspects of care. Okay. Your privileging list also has to have supervision of CRNAs or RNs if they give any anesthesia. Next, allergies and the reaction must be consistently documented and verified at each visit. Everyone does a great job of verifying the allergies, but about half of the centers we go to do not consistently document the reaction. It's okay if the patient doesn't know what will happen when they take penicillin because their mother always told them they were allergic to penicillin. So for reaction, you would just put the word unknown, okay? All your providers that use a C-arm or any lasers or ultrasound have to have privileges for the use of that. Next, all your drills must be scenario-based and have an evaluation. It's not enough to say, here's the fire drill, here's the date, here's who all participated. You have to set up the scenario. Where did this pretend fire break out? Who identified the fire? And what did they do? Okay. Next, you have to have a system in place to ensure that clinical records are complete, and that goes back to your chart audits. First impressions. A lot of people say, well, it shouldn't make a difference, but you know, one of the standards is that your center is clean and organized. You do need to have the appropriate signage. We're standing in the waiting room as surveyors waiting for the administrator or the DON to come and get us. We're looking to see that your rights and responsibilities are posted. I can't tell you how many times I've gone into a waiting room that, for lack of a better way to describe it, is dirty. Big stains on the carpet, broken chairs. You know, this is the first impression that your patients see. So there are standards for the maintenance and cleaning of the center. And surveyors are just like patients. That's our first impression. You want it to be a good one. Is there enough privacy? You may not have a separate room to register patients, but do you have a little area We look at the timeout. Now, almost without fail, every center for the case we observe, they do a timeout. But oftentimes, it's the nurse calling the timeout, or if it's the provider that calls the timeout, and people are busy setting up or talking to each other in the OR or talking to the patient. Timeout means everyone stops during that timeout. They stop what they're doing. They stop talking and listen. Okay? We're the entire time we're there, we're looking at appropriate PPE, both in the OR, pre-op PACU. We're looking at PPE and we're looking at hand hygiene constantly. Okay, so what can you do? Test yourself. You have the handbook, audit it yourself. Go down and assign yourself, do you feel you're compliant, partially compliant? Do you have these standards in place? Make multiple inspections. Don't wait till the week before your survey. We like to say that you want to say survey ready. So, this is something you should be doing quarterly, doing your inspections. So now it's time for you're going to be reaccredited this year. Have a colleague come and walk through your center. If you have a sister center, perform a mock survey for each other, or hire a professional consultant to come and do a mock survey. This will decrease the stress. You're prepared, you've gone over it, you've had someone else, a fresh pair of eyes, come in and go over it. So be prepared, you know what to expect, share the responsibility. This isn't all one person's responsibility. A DON or administrator should not be working around the clock and working weekends for the past 3 months to get ready for the survey. Avoid the common deficiencies. Now you know what they are. Test yourself. Use the people that you know and friends you may have that work at other centers to come in and do a mock or at least a walkthrough, because they'll catch something that you look at every day and you just didn't see. So in essence, you just want to review. So I'll stop there and open up for questions.
Hey, Alicia, it's Susan.
Uh-huh.
Thank you so much. I'm just going to ask some of the questions that have been brought to our attention. First and foremost, are we able to share a copy of your PowerPoint with the participants today?
Yes, absolutely.
Okay, great. All right. Then our next question, is it okay if our QI committee meeting is done at the same time as the governing board meeting?
It is, because oftentimes in smaller organizations, the board is the QI committee. So that's fine.
Okay, great. Next question. What type of training are you referring to for physicians?
For the physicians, you have to provide infection control training for your surgeons that come there, including anesthesia. Now, if they're getting it somewhere else, if they give you evidence of that, that's fine. But they should be, a new doctor should get orientation so that they know this is where the crash cart's located, this is where the MH cart's located, here's where our fire extinguishers are, here's our policies and procedures. So just because, and I've actually had doctors say this, I did go to medical school. I understand, doctor, but this is a requirement that annually we review these things with you. And it doesn't have to be one-on-one. You know, a lot of centers use HealthStream or some other type of online, or we actually have a form that you can use that's a checklist to show we reviewed with the provider this list of things, such as, you know, our infection control guidelines.
Okay, great. Next question. Does AAHC have a template for the formal evaluation of the QI program, or do you have suggestions
No.
where to get one?
AAA does not have one. I've seen a lot of people create one, and what I have is something that I was working with a center, and they had one that was one of the best ones I had ever seen, and I asked them if they would mind if I use that one. So it is, you can create your own template. I've not looked online to see if I could find one that's already there. The most important thing is that you have something, because I would say only 10% of centers actually have a document that they're using. The rest have nothing, and nothing in the minutes about an evaluation either. So you want to do some type of evaluation, document it, and it should show up in the QI minutes and the board minutes. So.
Okay, great. All right, so we have a few more questions. Do surveyors prefer evidence of requirements via paper or electronic records?
Oh gosh. You know, it really doesn't matter. I'm probably old-fashioned because I grew up with paper. So, but we see more and more centers now that even have like all their credentialing. They have it on, you know, their share drive, or not share drive, but on their system. Personnel files, now a lot of people have that. It used to be that only the minority had EMR and ASCs, and that's gone fully reversed. Now it's probably about 80% of centers are electronic, and 20% are paper. So either's fine. We're used to doing both. And what we are told, you know, by AAA is to not request, if anything that you have electronically, we're not to request you to print that. We're to look at it electronically. So that's fine.
Okay, so would you say that everybody seems to be following the trend of going digital, though?
I wouldn't say everyone, but more and more people are. And a lot of them start out as sort of a hybrid, where they have a system that they schedule with and maybe has patient data, but they still complete pre-op, OR, you know, PACU documents on paper, and then they scan them into this electronic record. So majority of them start out that way, and some of them just stay that way, which is fine. And then some, especially GI centers, are almost always electronic, just because it's just so much easier for the physician. So right now there's no requirement, you know, from AAA or Medicare or anyone else that I know of to have electronic records. So
Okay.
Paper is still fine.
Okay, so next question. Do you have to have an on-site administrator to each center?
I'm sorry, could you repeat the question?
You have to have an on-site administrator for each center?
Mhm. No, you do
Okay.
not. You have to have someone in charge at each center. So I would have some people have a director of nursing, some have a clinical coordinator. I mean, you can, you know, that role can have any title you want to assign, but someone at each center should be in charge.
Okay, great. I'm just going through some of our other questions. We have a lot of repeats. And somebody had also asked again about the QI checklist that Alicia was sharing, and we'll get that off as well with the entire presentation. And Alicia, we have a question here, and forgive me, I'm not sure if this is in the presentation, but how do I get a copy of your template for training for MDs?
Oh, if they will give you your their contact information, I'll send it to you, Susan.
Okay, sounds perfect. Thank you. Next question, does the training need to be repeated after orientation?
Yes, annually.
Okay.
So you have, yes.
All right, I think, looks like we've covered through all of the questions. Oh, I take that back. We've got one last one coming in here. Does the person in charge have to be an RN?
No.
Okay.
I think people, you know, assume it has to be an RN, but I've been to a couple centers recently where the person in charge, the clinical coordinator, was a scrub tech. Now they have RNs, and you know the RNs, you know, for the OR and for PACU. Also, I'm seeing some centers in pre-op will have LPNs, but they always have a minimum of one RN. But then, depending upon the specialty, some people use LPNs, and then I've even seen some real big busy centers, or you know, a tiny little small center that in addition to the RN, they'll have an MA in pre-op. But in PACU, they're all RNs. You may have an MA in PACU that's changing the beds and cleaning the spaces, you know, the bays, but and
Okay.
transporting, that kind of thing.
Okay, and then we also have one question. It's a twofold for you and for Accreditation. So first, I'm going to pass it to you, Alicia. Describe what a HIPAA audit consists of. And then the next part of the question is if we have a template for that. So Alicia, if you want to take that first half.
Yes. Yes. For HIPAA, I don't have a template. I have had some people say that it didn't pertain to them because they were a private enterprise or a government agency, but HIPAA does pertain to everyone. What I suggest for HIPAA is, number one, that you're doing some HIPAA training at orientation and then annually, and all your staff, including doctors, sign a confidentiality agreement, and you keep that in their personnel or credentialing file. And then the other thing is pretty much use common sense. You know, make sure your computer screens don't face the patient. make sure they time out after so many minutes. Make sure that if you're talking to someone at the front desk, particularly if you're asking a health question or a financial question, if it's something of a sensitive nature, everyone doesn't have a private space that they can take the patient into to talk to them, but you want to be sure that you're using, you know, a low voice and you know, if it is, especially if it's something health related, can it wait until you have the patient in pre-op?
Okay, great. Well, I know we are about at time for everybody. If there's any other questions, certainly feel free to reach out to us here at Accurate. But to conclude today's educational webinar, we just wanted to thank everybody for joining today's webinar. And a big, big thanks to Alicia for sharing her accreditation compliance best practices. And we certainly hope everyone's gained a useful insight to prepare for a seamless and stress-free survey. We invite all of you to join us each month for a series of educational webinars. Be sure to check your emails for the monthly topic. And also you can find us on LinkedIn and at Accurate Accred on Facebook and Twitter. Just be sure to follow us for updates. We appreciate everybody's time today and hope you all have a great rest of the afternoon.